Today's topic is normal labor. Definition: series of events that take place in genital organ in an effort to expel the viable products of conception out of the womb through the vagina into the outer world is called labor. Preterm labor, when labor occurs prior to 37 completed weeks. Delivery is the expulsion or extraction of a viable fetus out of the womb. It is not synonymous with labor. Delivery can take place without labor, as in cesarean section. Normal labor, also known as a eutosia, labor is called normal if it fulfills the following criteria: spontaneous in onset, at term, with vertex presentation, without undue prolongation, natural termination with minimal aids, without having any complications affecting the health of the mother or the baby. Abnormal labor is known as a dystocia. If any deviation from the definition of the normal labor is called the abnormal labor. Date of onset of labor based on Nicholas formula. Labor start approximately on the expected date is in 4%. 1 week on either side is 50%. 2 weeks earlier, 1 week later is 80%. At 42 weeks in 10%. At 43 weeks plus in 4%. Causes of onset of labor: endocrinal, biochemical, and the mechanical. This is on physiology of the normal labor. Fetus hypothalamus secrete the corticotrophin releasing hormones which act on the fetal pituitary, which will causes the release of ACTH, which act on the fetal adrenal and will act on the placenta. That leads to the release of estrogen and causes the placenta secreted the oxytocin, prostaglandins, estrogen, and increases, and at term decrease in progesterone and increase in interleukin level. And in the mother, oxytocin releases hypothalamus, pituitary. Hypothalamus hormone will act on the pituitary gland, which causes the release of oxytocin, which act on the myometrial receptors, increases the gap junction, increased decidual prostaglandin F2 alpha labor, stretch receptor number and sensitivity, which lead to the uterine contractions and lead to the labor. Uterine distension, stretching effect of the myometrium by the growing fetus and the liquor amnion. Fetal-placental contributions, cascades of events activate fetal hypothalamic pituitary adrenal axis prior to the onset of labor, which causes a release in the CRH, increased release of ACTH. Fetal, which act on the fetal adrenals as shown in the previous picture. Increased cortisol secretion, accelerated production of the estrogens and the prostaglandins from the placenta. This is a pictorial presentation that showing the initiation of the labor. Estrogen increases release of oxytocin from maternal pituitary, promotes synthesis of myometrial receptor of oxytocin, progesterone, increased fetal DHAs and cortisol inhibits the conversion of fetal pregnenolone to progesterone. Contractile system of the myometrium, false labor pain, or the spurious labor, found more in primary gravida, usually appear prior to the onset of true labor pain by 1 or 2 weeks in primary gravida and by few days in multipara. Pre-labor, the premonitory stage may begin 2 to 3 weeks before the onset of true labor in primary and a few days before in multipara. The features are following: lightning, presenting part sinks into the true pelvis, hence diminishes the fundal height and pressure on the diaphragm. This is a presentation showing the phenomena of the lightning, a before and after the lightning. True labor pain characterized by the uterine contractions at regular intervals. Frequency of contraction increases gradually. Intensity and duration of the contraction increases progressively. It is associated with the shock, progressive effacement and dilatation of the cervix, descent of the presenting part, formation of the bag of four waters, not relieved by enema or the sedative. False labor pain, dull in nature, confined to the lower abdomen and groin, not associated with the hardening of the uterus. They have no other features of true labor pains, usually relieved by the enema or the sedative. Shaw is a profuse cervical secretions with oozing of blood from rupture of capillary vessels of cervix and from raw residual surface caused by suppression of the membrane due to stretching of the lower uterine segment. Expulsion of the cervical mucus plug mixed with blood is called the shock. Formation of the bag of water. Due to the stretching of lower uterine segment, the membranes are detached easily because of its loose attachment to the decidua. With the dilatation of the cervical canal, membranes tends to bulge into the canal. The liquor passes below the presenting part, forming the bag of water. During contraction, bag becomes tense and convex. After the contraction, pass of the bulging may disappear completely. This is almost certain sign of onset of labor. This is a pictorial presentation showing the forewater, hindwater. Now the stages of the labor. First stage, from the onset of the true labor pain to the full dilatation of the cervix. It is a cervical stage of the labor. Duration is 12 hours in primary and 6 hours in multiparous. Second stage, full dilatation to the expulsion of the fetus from the birth canal. It has a two phases, propulsive phases, expulsive phases. 2 hours in primary and 30 minutes in multiparous. Third stage is from the expulsion of the fetus to the expulsion of the placenta and the membrane. Duration is 15 minutes in both primary and multi. Fourth stage, it is a stage of observation for at least 1 hour after the expulsion of the placenta. Events in the first stage of the labor is the dilatation and effacement of the cervix. Second is a full formation of the lower uterine segment. Predisposing factor for the smooth dilatation or softening of the cervix, fibromuscular glandular hypertrophy, increased vascularity, accumulations of the fluid in between collagen fibers, breaking down of collagen fibers by enzyme collagenase and elastase. These are under the action of hormones, estrogen, progesterone, and the relaxin. Dilatation of the cervix. Actual factors responsible are the uterine contractions and the bag of the membrane. Uterine contraction and retraction. The longitudinal muscles of the fibers of the upper segment are attached with the circular muscle fibers of the lower uterine segment and the upper part of the cervix in a bucket holding fashion. With each uterine contraction, not only the canal is opened up from above down, but it also becomes shortened and retracted. Bag of membranes. With the onset of labor, the membranes attached to the lower uterine segment are detached, and with the rise of intrauterine pressure during contraction, there is herniation of the membrane through the cervical canal. There is a ball well-like action by the well-flexed head. Uterine contraction generate hyperostotic pressure in the forewater that in turn dilate the cervical canal like a wedge. Dilatation of the cervix, fetal excess pressure. In labor, there is a tendency of straightening out of the fetal vertebral column due to contraction of the circular muscles of the body of the uterus. This allowed the fundal contraction to transmit through the podalic hole into the fetal axis and hence allows mechanical stretching of the lower segment and opening up of the cervical canal. This a turbo. The final phase of dilatation and retraction of the cervix is achieved by downward thrust of the presenting part of the fetus and upward pull of the cervix over the lower segment. This phenomenon is lacking in transverse line. Effacement of the cervix. It is a process by which the muscular fibers of the cervix are pulled upward and merges with the fibers of the lower uterine segment. The cervix becomes thin during first stage of labor or even before that in primary gravida. In primary gravida, effacement precedes dilatation of the cervix, whereas multipara both occur simultaneously. Formation of the lower uterine segment during labor, the demarcation of an active upper segment and a relatively passive lower uterine segment is moved now. The wall of the upper segment becomes progressively thickened with progressive thinning of the lower segment. A distinct ridge is produced at the junction of the two called the physiological retraction ring. This is a pictorial presentation is the dilatation and the taking of the cervix. Events in the second stage of the labor. This stage is concerned with the descent and delivery of the fetus through the birth canal. Propulsive and expulsive. Propulsive from the full dilatation until head touches the pelvic floor. Expulsive since the time mother has irresistible desire to bear down and push until the baby is delivered. With full dilatation, membranes usually rupture and there is escape of good amount of laca remnant. Active and passive segments of the uterus. Sequence of the development of the active and passive segments of the uterus. This is the normal presentation of the uterus at term. In early stage of the labor and deep which represent the late second stage of the labor. This is a expulsive, the pressure, uterine contraction, mother pushing down, and the visitago helps all the forces helps in the downward expulsive force of the uterine contraction. Events in the third stage of the labor. This comprises the phase of placental separation. It descends to the lower uterine segment and finally its expulsion with the membrane. Mechanism of separation. Marked retraction reduces effectively the surface area at the placental site to about its half. The plane of separation runs through the deep spongy layers of the deciduum bacillus. There are two ways of separation of the placenta. The central, that is known as the Schultz detachment at the